Good morning, everyone. Today I will be presenting a case. 4-year-old Leo was brought to the pediatric neurology clinic by his parents, who were deeply concerned about his persistent motor delays and changing physical appearance. Looking back, his mother recalled that Leo had been a floppy baby since birth, exhibiting significant hypotonia. He had been slow to roll over, slow to sit up, and did not walk until he was 2 years of age. Lately, his parents noticed a slowly progressive weakness. Leo struggled to climb the stairs and frequently fell. When the neurologist examined him, several distinct physical features stood out. 1. Facial dysmorphism, a notably long narrow face with an abnormally short jaw. Bulbar weakness, that is, mild facial weakness, gave him an expressionless appearance along with the high-arched palate. Skeletal changes, early signs of kyphoscoliosis and high-arched feet. Muscle weakness in the form of diffuse symmetric weakness in both the arms and legs. Most concerning to the clinical team, however, was Leo's breathing. He showed signs of respiratory fatigue out of proportion to his general limb weakness, a dangerous red flag in congenital myopathy. The diagnostic journey went like this. To uncover the root cause, the medical team initiated a structural diagnostic workup. Initial screening, serum creatinine kinase. The blood test returned at 145 units per liter, which is completely normal. While normal CK rules out the typical dystrophies like Duchenne's, they are highly characteristic of certain slow myopathies. Electromyography was done. An EMG of the vastus lateralis demonstrated non-specific myopathic changes including short duration, small polyphasic motor unit action potentials. The muscle biopsy. To get a definitive answer, a muscle biopsy was performed. Under standard light microscopy, the tissue showed a classical structural imbalance, a predominance of type 1 muscle fibers, selective atrophy of type 1 fibers, and a striking deficiency of type 2b fibers. However, definitive breakthrough came when pathology lab applied modified Gomori trichome staining. Notice the dark, dense purple-red accumulations packed within the blue-green muscle fibers. This distinct granular appearance is caused by thousands of microscopic rod-shaped aggregates crowded inside the cytoplasm. These are hallmark Nemaline rods. To fully characterize these structures, the sample was sent for electron microscopy. The electron microscopy scan revealed that these rods originated directly within the Z disc of the muscle sarcomere, maintaining a structural continuity with the thin filament. When cut transversely, the rods formed a highly organized regular tetragonal filamentous array, displaying distinct periodic lines running both parallel and perpendicular to the long axis. Biochemical analysis of these rods confirmed they were composed of proteins normally native to the Z-line: alpha-actinin, desmin, nebulin. Genetic profile and final diagnosis. Given the clinical picture and the presence of Nemaline rods, the diagnosis was finalized Nemaline myopathy. Because the condition is genetically highly heterogenic, Leo underwent targeted genetic sequencing. The test identified a compound heterozygous mutation in the Nebulin gene located in the chromosome 2 Q22.2. This genetic finding confirmed that Leo had the classical slow progressive autosomal recessive form of the disease. It ruled out the severe rapidly fatal infantile variety, which is often associated with intranuclear rods rather than cytoplasmic ones. The long-term management plan. Because there is currently no specific targeted cure or treatment for the Nemaline myopathy, Leo's management team shifted focus towards proactive supportive interventions to maximize his quality of life and guard against his own complications. Orthopedic support. Leo was fitted with custom ankle-foot orthosis to stabilize his high-arched feet and to improve his gait. The orthopedic team initiated close monitoring of the spine, preparing for early bracing or future surgery to maintain his progressive kyphoscoliosis. Pulmonary protection. Due to his disproportionate respiratory weakness, Leo was paired with pediatric pulmonologist for regular nocturnal pulse oximetry screening and baseline lung function testing, ensuring timely introduction of non-invasive ventilation if his breathing worsened at night. Cardiac monitoring. Though less common in the NEB mutations than other variant, Leo was scheduled for baseline and annual echocardiogram to screen for early signs of cardiomyopathy. Through coordinated physical adaptation and a careful specialist oversight, Leo's family found a path forward to manage his slowly progressive condition safely and predictably.